Hi, everybody. It's Professor Miller. This lecture is going to cover the structure and function of the renal and neurologic systems. I'm going to move through it relatively quickly. A lot of it's review from your A&P courses. I will point out some important factors to kind of think about, though, because when we get to abnormals, it'll kind of fall into place better. So in terms of the kidney, there's obviously different structures. The kidney is what we would term a retroperitoneal organ. So it's located in the abdominal area, but it's more towards the posterior side of the body. They're tucked right under kind of the ribs at the posterior side. And a lot of times patients that will have, like for instance, if they had kidney stones or even a upper kidney infection, they may present with flank pain. We'll typically call it flank pain because it's in that back area below the ribs. There is the renal capsule, which is basically a fibrous sac that's around the kidney for protection. And the renal fascia is basically like a connective tissue that holds the kidney in place. The hilum is more of that medial area of the kidney where the vessels and nerves essentially enter the kidney. And then on the next page, or I'm sorry, 2 slides down, I'll show you some more. But you have the major and minor calyx. Basically, those are where like the urine collects, and then it goes down to your ureters. And obviously, this is on both sides with both your kidneys. In terms of the other structures that you have to really think about too is blood flow to the kidney. So a lot of times, obviously, the vasculature, with your aorta and your inferior vena cava, all of this obviously feeds into and out of your kidneys. Because obviously the big portion of your kidney is to filter blood and cleanse your system essentially, or excrete waste. And it also, another important factor is electrolyte and fluid balance, as well as acid-base balance. So these are just important things to kind of think about. Your ureters obviously come down from both sides, coming down to your urinary bladder. And then we'll kind of take a look at that too as we move into further slides. As I mentioned, you have the cortex, the medulla. So those are basically, your cortex is more of the outer portion and the medulla is basically more towards the middle. And what we call this entire area would be the, like the renal pyramid essentially. It's this entire area that composes both of them. As I just mentioned, the calyces are the major and minor. So obviously you have the minor ones, which are essentially a little bit smaller, and that's right where urine collection basically takes place, and then it feeds down into your ureters. So when we look at this too, like they'll say that the structure of a kidney essentially is a lobe, and your lobe would consist of essentially like one of these areas here that includes like your cortex and medulla. So that's just like a structural name that we would term it. In terms of your kidneys, obviously, like I said, the major function is cleansing your blood, making sure that we're getting rid of waste. So obviously, when we look at the function of a kidney, we really look at the nephron. So the nephron basically has a lot of different functions, but they all kind of stem back to, excretion of waste, electrolyte balance, etc. Your glomerulus is basically like that small. Obviously the nephrons are small too, but it's basically, that's like the filtering center of the kidney. And we'll talk about this more as we move through. But it's essentially like a strainer, so that basically we're keeping the fluids and substances that we need in the body while letting out fluids and waste that we do not. There's tons of nephrons in the body, and we'll take a look at these as we move further through. But obviously, too, your blood enters, and that's what's cleansing it, and then it's excreted back out. Obviously, the waste is excreted in urine. This is just another image, the position of your kidneys, the structure of the kidney. The nephron, like I mentioned, is the functional unit of the kidneys. Its main job, obviously, is to filter urea and excess salts and water from the blood. It's part of the excretory system. It does have endocrine components, too, because it does have an effect on secretion of hormones, which we'll talk about, too. But urea, obviously, must be removed from the body because it's a toxic substance. So obviously increasing levels of urea can have some major significant effects on the patient. So the kidneys, once again, they produce urine. It's a high pressure system, because of the vasculature that kind of moves through the filtering system. So a lot of times, like your cardiac output and blood flow to the kidneys, has a significant effect on the filtration and function of the kidneys, essentially. The other thing too, on top of basically maintaining electrolytes, you got to think of it too, is really they have a significant impact on regulating blood volume and blood pressure. when we think about renin and aldosterone and all that, and where retain sodium in fluids, obviously that's where this comes from. So not only is it maintaining, our electrolytes, but it also maintains our volume of our blood. It does have an impact too, like on vitamin D, and I'll talk about that later, but there's some issues that can present with abnormalities with vitamin D. Like if you have chronic kidney disease, these patients, may have low vitamin D levels. The other factor too that you'll see very commonly is anemia. And we'll talk about this in the abnormals, but your kidneys have a significant influence on erythropoietin, which basically stimulates your bone marrow to produce red cells. So this becomes, problematic when you have abnormal function of the kidney. And we'll talk about that as we move through abnormals. As I mentioned, your the glomerulus is basically the filtrate. So that's kind of where it comes in, and this is where the major filtering takes place. And then obviously too, as you move through your kidneys, you have different loops, like your proximal convoluted tubule. I don't expect you to memorize each section and what it absorbs, what it doesn't absorb. I just want you to have an idea of what it affects. So like understand that it affects obviously your sodium levels, your chloride levels, your potassium levels, bicarb. So that's why, obviously it affects your acid-base balance. And I know you talked about this previously, with acid-base. Secretion of creatine, reabsorption of water. So I want you to have like a good overall picture of, what it affects. So if you have a dysfunction here, you have kidney disease, obviously all of these areas can become abnormal. You may not have good acid-base balance. You don't have that compensation mechanism there. You may have fluid or electrolyte disturbances, or even other things like when you see glucose. Remember how we talked about diabetes, and sometimes if it's significantly elevated, they can actually have glucose in the urine. So really, when you look at this, don't memorize which one is exactly in which area. Look at it from an overall picture of what it can affect, essentially. As I mentioned, this is the same kind of thing, function of the nephron. So the big things I already mentioned, filtration. So filtration in the glomerulus is basically the filtering unit. Reabsorption, occurs along that renal tubule, and this is where a lot of those, the transport or secretion or reabsorption of fluids and electrolytes essentially takes place. And you could have, a deficit or a dysfunction in any portion or all of the portions of the nephron or the kidney, essentially. So obviously it's like a fine balance between what you secrete in your urine and what you reabsorb. So it's a pretty complicated system, essentially. So obviously part of it gets reabsorbed into the blood, and then obviously part of it, you secrete that waste or substances through that renal tubule. Obviously then it ends up into like the calyces, and then it moves into your ureters, essentially, to the bladder. In terms of nephrons, I already mentioned this. There's obviously a very significant amount of them. There's different nephrons. The cortical and mid-cortical are essentially kind of the same thing. One's just a little bit more towards the outside portion, which is the cortical. It's more on the edge, where mid-cortical kind of moved down a little bit further into, the kidney, essentially. The juxtamedullary nephrons, and I'll talk about this in the next slide. They have, a special function, essentially, and they are responsive to renin or secretion of renin. So that's the other reason why I wanted to kind of point that out, because we'll talk about that in a minute. But obviously, I already mentioned it's a functional unit of the kidney. Cortical nephrons, like I said, they're more towards that cortex portion, where your juxtamedullary are basically in the medulla, or the medulla. And these are responsive to antidiuretic hormone. So that's why they're obviously have a very important function. So when they're responsive to antidiuretic hormone, think about what the function of antidiuretic hormone is, and basically the maintenance of fluid volume, sodium and water reabsorption, essentially. And these kind of more function towards concentrating the urine. So they kind of have a special place, in terms of the functioning of the nephron. As I already mentioned, the juxtaglomerular cells basically have the renin releasing capability. And the macula densa are sodium sensing cells. And I have more pictures as we move through. So it's important, like I already mentioned, like the macula densa ones that are basically a portion of that nephron, they sense sodium levels. So if sodium levels are low or high, that's what initiates the response of sodium and water retention essentially. Same thing with renin. So those cells basically release renin in times of need. So that's why these cells basically kind of help regulate fluid fluid and electrolyte status. Both of them together really control your renal blood flow too, because obviously this is what's increasing the volume of or your blood volume essentially when you're reabsorbing this. And also obviously your renin secretion has a significant effect on blood flow, which ultimately affects your GFR. When I say GFR, that's your glomerular filtration rate. And essentially that means how well your kidneys are functioning or filtering. And it's usually like given over a period of time when we check it in blood work. But the higher, obviously you want a normal GFR, but when it is reduced, that's not good. Like when they have a lower GFR, it means that their kidneys are not functioning well. So obviously things, if they have poor perfusion to the kidneys or hypovolemia where they have low blood volume, all of these factors obviously can affect your GFR and the functioning of your kidney. This is just what I was mentioning. Here's a picture to kind of put with it. The macula densa, basically, these cells sense low fluid or low sodium concentrations. So these kind of work in conjunction. And then your juxtaglomerular cells basically secrete renin. Remember what renin does. You got to think about the whole process here. So the kidneys basically release renin into the bloodstream. And then you have that whole renin-angiotensin system where you have angiotensin 1 to angiotensin 2. But remember, we got to think about what the ultimate effect here is too. So they get vasoconstriction. It also stimulates your adrenal cortex. And remember, we talked about that too, where your adrenal cortex has an impact on antidiuretic hormone and aldosterone, obviously. So that's why, once this gets stimulated or these cells basically sense this, you have aldosterone basically stimulates sodium uptake. And then obviously too, you have antidiuretic hormone, which affects your water reabsorption as well. So that's what's basically maintaining that blood volume and sodium levels. So these, if you think back to the kidney, this is how it's kind of regulating that. And then obviously the secretion of renin that goes alongside with it. This we've already kind of talked about too previously about antidiuretic hormone. So once again, this is another area that, it's detected basically that, the hypothalamus detects that there's low volume there essentially. So but basically stimulating the pituitary gland to release antidiuretic hormone. So more water moves from the filtrate back into the blood. So then that's what's bumping up your blood volume and your blood pressure. In terms of urinary structures, like I already mentioned, you have your ureters. They're relatively long. That's what's going down from your kidneys down to your bladder. They're, it's composed of smooth muscle, and there's peristaltic activity, basically kind of pushing that urine down to the bladder. And I'll talk about this in a minute, but micturition basically means urination. And a lot of this is regulated by your nervous system. It senses the stretch in the muscle of the bladder. But micturition basically compresses that lower end of the ureter to avoid urine reflux. When we have patients that have reflux, basically that can go back up to the kidneys, they're at high risk for infections because it goes back up and they end up with, not always, but they can end up with pyelonephritis, which is an infection of the kidney. So the urination, obviously, too, like I said, and I'll show you on the next slide, but a lot of these, your muscles in here are smooth muscle, and it has stretch receptors or mechanoreceptors in there that send like a reflex back up to your brain, essentially, for parasympathetic control. Actually, it's under the parasympathetic control, and that's what basically senses when your bladder needs to empty, essentially. Now, your external sphincter, because you have internal and external. Your internal is still under the control of your nervous system, so it's involuntary. Where your external urinary sphincter is actually more voluntary controlled. So that's what inhibits urine flow, obviously, even if you have a full bladder. In terms of other structures, the detrusor muscle, the trigone, so the detrusor muscle is like the major muscle of the bladder. And a lot of times too, like when we talk about like overactive bladder, it can affect the detrusor muscle, or they have like an overactive muscle there, and that's why they get the symptoms of overactive bladder. The urethra, in terms of men and women, they're obviously very different lengths. It's very short in females versus longer in males. And actually, this is why a lot of times women are at more risk of having urinary tract infections versus men. It's just the anatomy, they're more predisposed to getting urinary tract infections. And as already mentioned, there's internal and external sphincters. That internal one is under parasympathetic control versus your external is under voluntary control. This is just an image, like I was mentioning, like the reflex arc that basically controls that, the filling of the bladder, or sensing the filling of the bladder and the need to devoid, essentially. I already kind of went through those. In terms of renal blood flow, so the big thing to remember here is understanding, like, if you have a reduced renal blood flow, obviously it affects your kidneys and it's going to affect the filtration rate. So certain things, like when we talk about like acute kidney injury, there's certain factors that can cause acute kidney injury, whether it's a blood flow issue or it's intrinsic, meaning within the kidney, or after the kidney. So there's different reasons why patients can have like acute kidney injury, essentially, or acute kidney failure. So the big thing is blood flow. If they don't have a significant amount of blood flow, or their blood flow is reduced, whether it's dehydration or hemorrhage, obviously in the end, it's going to affect the kidney function. Under normal circumstances, if like your blood pressure drops a tiny bit, where it kind of bounces around a little bit during the day, there's compensatory mechanisms there where it's not going to really affect renal blood flow. But we're talking about significant things, like if they had hemorrhage or severe dehydration or sepsis, or anything that's going to affect blood flow, that's when they're at risk for more of like acute kidney injury. But a significant amount of your cardiac output actually goes to your kidney. It's like 20 to 25%. So they receive a lot of fluid basically going through there. I'm sorry, a lot of blood flow. 1,000 to 1,200 milliliters of blood per minute. So it's a lot that it's filtering. In terms of, the output, and when we look at urine output, typically what we would say is normal is at 30 mLs an hour. So it's really important when you think about this from a clinical perspective, in the hospital setting of, is your patient, have normal urine output? If they have a decrease or decline in urine output, that's a red flag. So that's one thing that you always look at. If they have, if it's kind of trending down, you always look at trends, but if they have a decrease in urine output, it's kind of a red flag, like something's going on. So other things, perfusion pressure. So low perfusion in the afferent arteriole stimulates renin secretion. So like I just said, if they have low, when we say afferent, is basically afferent's going to. So when there's low pressure in those arteries going to it, that's what stimulates renin secretion. So then it's going to basically try to bump up or compensate and increase the blood volume. If they have high perfusion states, so if they have, significant flow going there, or excess fluid volume, it's going to inhibit renin secretion. So it's going to kind of halt that so that they're not increasing the fluid volume anymore. Sympathetic activity. Sympathetic activity is obviously from your nervous system. So when you think about this, it's going to basically increase renin secretion. And then another thing too is you can have vasoconstriction with sympathetic activity too. But like I mentioned, if you have a low blood pressure, there's going to be an increase in renin, and that renal blood flow and GFR is basically maintained by these factors. And that's another reason why too, like there's a constant rate of renal blood flow because of these mechanisms essentially that are in place. Some of these I already talked about, like anti-diuretic hormone, and we've talked about this before. So basically, increased permeability of water, so increasing fluid retention. And this is actually a good example. It's inhibited by alcohol and coffee. So if you drink alcohol or coffee, they're diuretics essentially. So it's because it's inhibiting anti-diuretic hormone. That's why a lot of times you'll urinate a lot if you drink a lot of coffee, or anything with caffeine in it too will do that. But it inhibits anti-diuretic hormone. The juxtaglomerular apparatus, like we already kind of mentioned, that's what senses or I'm sorry, not senses. This is what's regulating renin. Remember, the macula dense is what senses it, but basically this is that part that stimulates that whole renin-angiotensin response. So that's going to increase your blood pressure and blood volume. Angiotensin 2, we kind of already talked about that too. It goes alongside with that. And then you have, and I'll talk about this in a little bit, but you have factors like natriuretic factors or proteins essentially that are from the heart. Like we'll check your BNP level. So basically what happens is when you have muscle stretching of the heart, like let's say if the patient has heart failure, the cardiac myocytes will actually release these factors. And basically this is to do the opposite. So it's going to basically stop renin release and decrease salt reabsorption because it's trying to reduce blood volume. So this is kind of like the opposite mechanism. Like these we're trying to increase, where this actually is a mechanism to kind of decrease blood volume. Because like in heart failure, when you think about it, they have fluid volume overload a lot of times. The heart starts stretching because obviously it's not effective anymore, but it senses this. And that's why these other factors are secreted to try to kind of regulate this and decrease the volume of blood or cardiac workload, essentially. So I'll talk about that too as we move through a little bit more. These are things I already talked about. It's just another image that you can kind of put with it. Your renins, angiotensin renin system with aldosterone that basically increase sodium reabsorption, and then that's what's increasing your blood volume and blood pressure. So the big things to think about here, if you have low blood volume, it can, like if it's severe enough, it can affect your kidney functions. That's why these mechanisms are in place, basically to support kidney function too. So that's why, you'll start reabsorbing sodium, and that's going to increase your blood volume and your blood pressure again too. Your sympathetic control, that will basically cause vasoconstriction, which is going to increase your blood pressure as well. So as you know, a lot of this will regulate your blood pressure. I think you guys already know about the renin-angiotensin system, but the big thing, like I already mentioned, you have aldosterone, which increases water and sodium retention, which is increasing preload. So basically, it's increasing the blood pressure. In terms of assessment of renal function, the big thing that we look at is your glomerular filtration rate. So this essentially tells us how well the kidneys are functioning. So this is one of those key things that we look at. And it's looking at how well it's being filtered at a given time. It's looking at basically over a minute. And there's normal values. For men, it's a little bit higher versus women. When we do calculate it, they do put things in, obviously, their gender. They do put in their age. These are factors that we look at when the GFR is calculated, essentially. And the lab usually will give you a calculation with it because it's using creatine as well, your creatinine clearance, basically to estimate it. And I'll talk to you about creatinine as well, and we'll talk about this more with abnormals, but they use both of these to kind of develop that GFR rate. And we use creatinine because it's a good measure that's pretty constant, that's constantly, excreted through the kidney. So we're looking at how well it's being excreted through the kidney. I accidentally had this in here, but this is kind of going back to the blood flow and your GFR. So blood flow, obviously, like I already mentioned, has a significant effect on your GFR. Neural regulation, these are going back to the other things that I was kind of talking about. I already kind of went through these. Basically, like there's not a significant parasympathetic. It's more of your sympathetic nervous system that's basically regulating that blood flow. It's not parasympathetic. So it's sympathetic. Hormones such as your renin-angiotensin system, natriuretic peptides, which are the ones that I just talked about, basically going the opposite way and reducing the volume essentially. In terms of the function of the nephron, basically it's what's filtering your plasma. So obviously that's the big function of it. It's reabsorbing and secreting. So you have tubular reabsorption and secretion. So obviously it's holding on to things that your body needs, whether it's sodium, obviously water, potassium, things like that. and secreting things like urea or creatinine, things like that are secreted, obviously, are toxins. And that's another big thing, too, when we look at, when you get into pharmacology, there's certain meds that are nephrotoxic, or a lot of meds are secreted through the kidney. So a lot of times, too, if a patient has, dysfunction of the kidney, we have to make sure we're accounting for that when we give them certain medications, because some of them can be harsh on the kidney. Or if they have decreased kidney function, they don't excrete it well, and then they can be at risk for toxic levels. That's just a side note. But it's a filtrate. Obviously, we kind of talked about this, the protein-free fluid. So protein should not be going through the kidney essentially and excreted in the urine. If there's protein in the urine, that usually is an underlying indicator that there is kidney damage there. And we'll talk about that with the abnormals, because sometimes with an abnormal state, you'll see protein in the urine. So it should not be secreting protein out in the urine. Same thing with glucose. When we talked about glucose going into the urine, that's usually when there's a huge elevation in the patient's glucose level and they start secreting glucose through the urine. Obviously, it regulates and filtrates to maintain fluid volume, electrolytes, and your pH, so acid-base balance as well. Glomerular filtration, it's permeable to water, impermeable to large molecules, which is like proteins, which I kind of already mentioned just a minute ago. Like I said, we shouldn't be basically secreting proteins out through the urine. If we do, there's usually a problem. Tubular reabsorption versus secretion, I kind of already mentioned this, where you're reabsorbing factors that we need versus ones that we do not. Net filtration pressure. So a lot of this is managed by, capillary oncotic pressure or hydrostatic pressure. So that pressure that's going into the glomerulus basically is what creates the movement, basically. So that's why if they have a low filtration rate or if they have low blood volume, it can affect the filtration of it because it affects oncotic pressure there. Filtration rate is very significant. It's 180 liters a day. So when you think about that, it's a huge amount of blood that we're filtering through our kidneys. So it's very, very significant. The current exchange system essentially is basically with the tubules, and basically this is what's concentrating the urine. So it's basically the mechanism that kind of follows through the loops to basically support reabsorption and excretion of solutes, essentially. And basically that's what, in the end, it's what's providing the concentrated urine. In terms of hormones and renal function, these are ones I already talked about, like your anti-diuretic hormone, aldosterone, natriuretic peptides. Those are the ones I mentioned by essentially with the heart. So if there's stretch of the heart, there's basically those mechanoreceptors that sense the stretching of the heart because of the increased fluid volume, basically. So then now it's going to kind of turn it the opposite way. So then they're going to inhibit sodium and water retention, essentially. And aldosterone secretion. So it's kind of an opposite, more protective mechanism, essentially. C-type peptides are basically secreted from the endothelium, or the vascular endothelium, and basically increases vasodilatation to the nephron, or in the nephron. Urodilantin is basically secreted by the renal tubules, the distal tubules, and they cause vasodilatation and like a diuretic effect. When you get into pharmacology too, you'll talk about different diuretics, and a lot of them work in different areas of basically the nephron, and a lot of it is basically regulating sodium and water retention or excretion, essentially. But obviously the function of the diuretic is to increase urine output, and usually it's in a state where they have fluid volume excess, like in CHF or something like that. But the problem with a lot of diuretics, and it's an area that we have to look at, especially with loop diuretics like Lasix, which Lasix is used a lot to treat like heart failure, where they have peripheral edema or pulmonary edema. So we want to get rid of that fluid. But unfortunately, what happens, it depends on where it works in the nephron. Some of them will have potassium loss with it, so the potassium kind of goes out with the fluid, and then sometimes we have to replace the potassium because we're at risk for hypokalemia. Some of them, we do have potassium sparing diuretics, so they work at a different portion of the nephron. and they actually hold on to potassium. They're usually not as an effective diuretic as like a loop diuretic. That's why loop diuretics are used pretty often. So essentially, I just figured I'd talk about that while we went through this. As I mentioned before, I don't think you need to memorize every single portion, of the loops or anything like that. But this is just a good example of, like, if you place it with a diuretic, it'll kind of make sense too. Like we have a lot of potassium sparing diuretics that work, higher up towards the glomerulus, and they tend to have more potassium. They retain potassium with it. But we also have loop diuretics that are here, but loop diuretics usually do a significant amount of diuresis essentially with it. There's different ones like osmotic diuretics, and they basically pull fluid out through, an osmotic pressure essentially with it. And mannitol is kind of another one that does that too. But a lot of times you'll see thiazide diuretics used and you'll see loop diuretics used. Thiazide diuretics don't produce a significant amount of diuresis like a loop diuretic would, but they're at less risk for hypokalemia too. Where loop diuretics work very, very well, but they also get hypokalemia with it. Other hormones, as I mentioned too, like it does have some control over endocrine function as well. Vitamin D basically can be affected, and erythropoietin can be affected. So these patients can actually in patients with renal failure or chronic renal failure are predisposed to issues such as like anemia or calcium deficiency, or which affects their bones, and vitamin D deficiency. So basically, like for instance with erythropoietin, when a patient has like a low oxygen state or decreased tissue oxygenation, the kidneys basically secrete erythropoietin. This actually is what stimulates your bone marrow to increase red blood cell production. While they lose that, function there essentially, so they don't have a good response of erythropoietin, and then they don't have a good response on the ultimately on the bone marrow. So then they end up with anemia. So we call this a lot of times with chronic kidney failure the anemia of chronic disease. Or anemia of chronic kidney disease. So it's very common for these patients to have anemia, and we'll talk about that with abnormals as well. They also have decreased plasma calcium levels, which will stimulate your parathyroid hormone, because remember your parathyroid hormone affects calcium. And it basically is trying to restore normal calcium levels, but a lot of times what happens is the calcium moves from your bone into the plasma. So then obviously when you do that, you have reduced calcium for bone reabsorption essentially. This is just another image and to kind of put with it. But like I mentioned before, if they have damaged kidney, they have decreased erythropoietin, and then they end up with a decrease in red cells, which obviously will put them into an anemic state. So that's not uncommon for patients with chronic kidney disease to have anemia. Low concentration of calcium in the blood. Remember, that's where your parathyroid kind of kicks in. But like I said, there's usually the calcium from your bone is basically shifted into your blood to maintain calcium levels in your blood. And same thing with your calcium from your intestine. But obviously these patients then are at risk for like bone loss, and they can have obviously calcium imbalance and phosphate imbalance. And we'll talk about that with abnormals. In terms of tests that we look at for kidney function, we do look at the GFR, like I already mentioned, and we'll go through these as we go through abnormals because you have to put it with something. We also look at the creatinine level. The creatinine level is a very good indicator for kidney function, and so is the GFR. We also look at the BUN. The BUN is helpful when we're trying to figure out, like in a case of acute kidney injury, like is it a pre-renal issue or is it a issue that's originating within the kidney? And I'll talk about that through abnormals, but we try to determine, where the cause or the problem is, obviously, in order to correct it. So the BUN is a good supplemental tool to use. It's not very specific, I should say, to just the kidneys. That's the problem with it. So you have to kind of look at it with a big picture. Because your BUN can be elevated with dehydration, just simple dehydration, it can be elevated. Whereas your creatinine is a very specific indicator for your kidneys because it's more of that constant, how do I say it? It's more of one of those solutes that is excreted through the kidney at a constant rate. So when you start to see abnormalities there, it's a red flag. And we'll talk about that with abnormals. But we also use your creatinine level to determine your GFR as well. Urodynamic test, cystometry basically looks at the contraction of the bladder when you're voiding. This would be more in terms of like if they had, an innervation issue to their bladder. So that might be, a useful test to see how well the bladder is actually contracting. Uroflowmetry basically tracks the flow of urine, how fast, how much, like is it emptying, fast enough? So that would be another thing too, like you would look at, for dysfunction of the bladder. Post-void residual is a big one that you'll look at. And a lot of times too, you'll do this with ultrasound because patients can have urinary retention, whether it's related to some kind of nervous system issue or even post-operatively it happens. Certain medications can cause urinary retention. So a lot of times we'll look and see if they still have residual urine in their bladder. An EMG basically is like a nerve conduction study and looks at the muscle response with it. So that would be more if there was a concern if they had like a neurodegenerative disorder as well. And that's looking more at like the nervous system response with it. In terms of like direct visualization tests, basically it'd be like a cystoscopy or ureter, or a cystoscopy or a scope of your ureters essentially. And basically that's literally them looking at it with the scope. So they'll look at the bladder and your ureters essentially. And that would be like if you have like hematuria, like if they have blood in the urine, sometimes they'll go in and look at it with the bladder wall to see if, make sure that there's something going on in there. In terms of peds, I thought I would bring this up real quick. The same thing with the older adult. They're at risk for, renal dysfunction and fluid electrolyte imbalance, which kind of talked about before. But they basically, they're very, very high risk for electrolyte abnormalities. They are also at risk for our drug toxicity. They're, in a pediatric patient, especially younger, infants or real little ones, their systems are relatively immature. So a lot of times, obviously, that's why even when we dose medications, we're very cautious with, the nephrotoxicity of a drug and how much is given for a pediatric patient. But they also have a decreased concentrating ability. So just the function of their kidneys or the nephron is, not as an adult, essentially. So they're more at risk for electrolyte imbalances, essentially, with it. And then also, too, the risk of drug toxicity. Same thing with the aging adult. When you get older, a lot of times too, like they have decreased renal blood flow. So, the vascular systems are affected by it. And obviously when the vascular system's affected by it or your blood flow, your kidney function can be affected by it. So even your filtration rate can be affected. They're at, more risk for fluid and electrolyte disturbances. They're at more risk for perfusion issues. Same thing with acid bases. They have a delayed response, so the compensatory mechanism may not be as quick as it would be in a younger patient. Same thing again, they are at risk for drug toxicity because a lot of drugs are excreted through the kidney. And basically, if you have decreased kidney function, they hold on to that drug essentially, and then they can have toxic effects from that drug. Or there's drugs that are nephrotoxic, meaning that they can actually be hard on the kidney. But you'll get into that when you talk about this one in pharmacology, though. Just know that they're at risk, essentially, for this. And even like their alterations in thirst and water intake. So even that response to thirst is decreased in the older adult. So it's just another factor that contributes to, a fluid or electrolyte disturbance with them. The next lecture will be on the abnormals, and then we'll discuss more of them when we get to class. If you have any further questions, obviously, please let me know. Thanks. Have a great day.